Two, I see got a decent contingent. I'll
Yeah,
let you
so
start whenever you want, Chrissy.
okay, perfect. We'll go ahead and get started since it is being recorded. So folks that are coming in, if they wanted to hear the intros, they can. So first, we want to welcome everyone to our mental health virtual summit. So we have a few speakers today. We'll get into introductions in a later, but that's specific clinics and Provisio partners. Now, before we get started, our forward-looking statements, I know a lot of folks have seen this. So basically what this means is please make purchasing decisions on technology that is currently available. So we're going to get into some conversations about the industry, the space that we're seeing. So just keep that in mind. Now, the agenda for today. So for folks that may be registered a while back, or, can't remember what we're going to be talking about, this is what we're going to be talking about. And when we were putting together this agenda, working with Eleanor, who's a clinical trained psychologist, she helped kind of tweak the agenda a little bit. So what we're going to focus on is, why we're focusing on this mental health space. What are the complexities and the trends that we're seeing? We're going to talk about regulations and managing care. And then from there, we're going to talk about what it is that we need to make this happen. So what is the technology? How is this changing? Are we talking about a multi-channel approach? And then how do we actually undertake this? So what are we doing to help organizations undergo a digital transformation? So we'll go into those details. Speaking of that, as we're going, so little housekeeping, questions, conversations are welcomed. Please feel free to post in the chat, come off mute if you would like. For my more introverted folks, what you could do is if you wanted to, you could privately chat myself or Meryl. He'll be watching the chatter conversations come through. So feel free to jump in if you have any questions. We will also make sure that we have pauses too. So if you want to wait for that, you are more than welcome to. All right, so let's go ahead and meet our panelists. And so I'm actually going to hand it over to Eleanor and then Erica, and then I'll do a little introduction on myself. So Eleanor.
Good morning, everyone. Well, at least it's morning here in California for me. I'm Eleanor Castillo-Sumi. I'm Senior Vice President of Strategy, Innovation, and Growth at Pacific Clinics. Pacific Clinics is the largest nonprofit behavioral health provider in the state of California. We provide services to the full age continuum and the full service continuum. So from your prevention services to your high intensity community-based services. That includes mental health, substance use, education services. We also have Head Start, adult learning, as well as foster care and social services. So thank you. Thank you for the opportunity to be here.
And Erica, you're muted.
I am. Hopefully that's the last time that happens today. So my name is Erica Cox. I'm the managing partner and chief innovation officer at Provisio Partners. We have had the great honor to work with Pacific Clinics over the past, I guess it's over a year now, to implement some of the things that we're talking about today. I serve as the executive sponsor for that relationship, and also have architected portions of what we'll talk about today. Provisio Partners as an organization was founded solely to provide Salesforce solutions to human services organizations. So we work with organizations across the country on many of these challenges. And like Eleanor, I really thank you for taking the time to talk with us today. Chrissy?
Sure. So I'm a lead solutions engineer at Salesforce. Really what that means is I work with our customers on talking about your use case and aligning that tech to the technology. Also, I'm a specialist in social and human services. So that's really all I focus on. So that said, I think I want to take a step back and help for folks that have never worked with Salesforce, help to connect the dots on how we all work well together. So for those of you who haven't seen the show, there's a show called Property Brothers, and I always think this is kind of what we do when we work with our customers. So we have folks like Eleanor who come to us and they say, our organization needs to be more streamlined. We need to connect things. We need all the electricity and all the rooms to share the information that we need. They come to us. And then what happens is Erica and myself, so on the show, if you haven't seen it, there's these twins. One of them kind of helps figure out what it would look like, the design, the architecture of it. The other brother will actually make the dream become reality. So in this scenario, when you're working with Salesforce, you're going to have someone like myself who would look at exactly what you need, what technology we need to put in place, and how those pieces would come together and help you visualize that. Once you guys are ready to go, then we would bring in someone like Erica, and then they would actually take that vision and make it a reality. So I just wanted to take a step back and kind of show how it all works together. I will say one thing with working with Eleanor, while we're talking about technology, she truly, truly knows this space. While all of this was happening for a year, my child, so I'm passionate about the mental health, my child was going through school, going through IEPs, he had mental health struggles, and she was working with me on the side. We were texting each other. So I really appreciate all the work that you do. I'm very excited that you are in this space and we could all learn so much from you. So thank you, Eleanor. All right, now before we begin, Meryl has a poll for us. We want to see a little bit more about what you would like to hear about today. And this is going to help kind of guide us on where we need to lean in or maybe tone down. So feel free to take a second to let us know what you would like to hear about. We'll give it a few seconds and then
Yeah,
we'll...
responses are coming in. We've got about a quarter of the folks so far.
This is where people are grabbing their coffee. Oh, okay. Now I gotta...
We're up to half. Give it about 10 more seconds.
We got one more poll, so don't walk away too just yet.
All right, looks like we've got the bulk of everybody. So I will end the poll and let's share the results.
Okay, perfect. So leveraging technology to make receiving and providing care easier. Fantastic. All of it. Love that as well. Okay, well, that's good. At least we've got a rounded group. So Meryl, do you want to launch the next one? So we've given you a little bit more about ourselves, but we kind of want a better understanding of who is also here. So what role do you play with your organization? And we know that there's tons of roles, so we try to condense it down a little bit, again, because that's going to help us kind of figure where we should lean in.
And we've got about half of the folks so far.
Okay. And I promise this is our last poll for it. We'll get into it.
All right, that looks like we've got the bulk of everybody. So I'll go ahead and end that and share the results.
Perfect. All right. So it's fairly executive management and other. Fantastic.
Can we
Okay.
ask for those that checked others, if they can maybe just note in the chat what positions, just really briefly?
Yeah, if you guys have a second, go ahead and chat that in. For timing purposes, I'm going to go ahead and progress to the next piece. And then again, if anyone has any questions and maybe you don't want to put it in the chat for everyone to see, feel free to private message myself or Meryl. We will make sure that we ask our host these questions. All right, so I'm going to move on to the next slide. We're going to get right into the complexity. Take it away, ladies.
Oh, great. Sorry, I was busy trying to read the, the chats here. Shouldn't do that. So, you know, mental health was always a need prior to the pandemic, prior to COVID. And then over 2 years ago, we all shut down, literally shut down in the world. And the pandemic has accelerated, you know, the needs to provide behavioral health services. And I would say, you know, even today, we really don't truly know the impact of the long-term impact of the pandemic on people. You know, millions of kids lost someone to COVID. So the impact on that, we would imagine, would be, you know, lingering. So you have that as a, you know, the overlay, if you will, that's behind all of this, and a lot of funding from the federal level coming down to support behavioral health. But even prior to that, most providers like us have to navigate a number of different regulations. So from the federal side, you know, there are waivers, 1115 waiver is a current one. We have Medicaid waivers, Medicaid regulations, Medicare regulations, and that all influences then how the state then does business, and then that trickles down to counties. and then providers like us. So there are multiple layers of regulations that we need to deal with. Some requirements that most of you here are familiar with are things like HIPAA, and if you're working in the schools, FERPA, and how do all of these things, one organization whose mission is to be a trusted behavioral health partner, and to serve anyone regardless of their ability to pay, how we then all manage all of that. Erica, did you have anything that you wanted to add about regulations and all that from the IT standpoint?
I was just going to say thank you, Eleanor. It is important that you get a trusted partner in this. I mean, obviously, regulations and compliance are a conversation. It's unfortunately not as easy as saying we'll flip a switch and everything's good. It's a conversation. It's all about risk mitigation, and it's been fantastic working with Pacific Clinics, their legal team, and making sure that we have both the technical solutions in place and the procedural solutions in place, to allow, for instance, data sharing across their organization. So it just, just pointing out that it isn't, there's no panacea for it, and is going to still be complex and still be a conversation to work through together.
Yes. Alongside all these different regulations, you then also have the continuum of care, right? So from your prevention, I mentioned we provide prevention services all the way to your intensive outpatient services. So for us, that means wraparound, where the average wraparound recipient receives 6 to 8 hours of service a week. Sometimes it also includes 24/7 services. We no longer provide residential care, but wraparound is our alternative to residential care. And so the same level of care that's provided in residential is the same level of care that we need to provide within wraparound. So within that range of the continuum of care, that adds to the complexity. And I'll talk in a little bit about the different trends, but understanding your space, understanding the target population that you're serving are all critical in this larger landscape. And then just as a framework, the quintuple aim, we try to look at all the 5 different components of the quintuple aim to really make an impact. Starting with improving health outcomes, to enhancing the care experience for our customers, the experience of delivering services for our clinicians, our staff. If we don't have them, then there are no mental health services, as well as reducing costs and advancing health equity. And I'll go through them in more detail as we go through the slides. Next.
Yeah, and I just want to add one last thing. Some of the conversations that we've had with Pacific Clinics as well as other organizations is that the piece around when someone becomes a client. And sometimes we can't even put the workflows or the data that happens before they become a client. We have to wait for them to become a client before we can put them in something like an EHR. So that whole wraparound care that Eleanor was talking about is making sure that we have a place to manage the care from all the way from the beginning to all the way to the end. So if you get a referral list, or you get a referral coming from a school or a third-party organization, that's where it starts. That's where we start tracking things all the way through the care that they receive. So I learned that working with Pacific Clinics. So I wanted to make sure that we're putting kind of those placeholders in other people's minds. So we can go on to trends.
Yes. So probably one of the biggest trend out there is the push for integrated care. Customers want a more seamless experience. They want to be able to go, to a single place and get their full care, whether it's medical, so with primary care, behavioral, or social services, including social determinants of health. So for example, for adults who need support with housing or employment skills, the whole push towards integrated care is one of the larger trends today. Payment reform. So whether it's, again, in California, we're embarking on a system transformation, it's called CalAIM, California Advancing Medi-Cal, and Medi-Cal is California's Medicaid program. that essentially means that the payer is shifting from the counties to the health plans. So, the methodology of doing business, whether it's your payment structure, how you're documenting service, that is shifting. So we are currently in the midst of all of that. That CalAIM started January 1st of this year. So we're at, almost 9 months into it. But just in general, the health plan space is looking at moving from quantity to quality. And so value-based payment structures are a different way of doing business, as opposed to your fee-for-service where you have a CPT code that's associated with a rate. Getting an organization ready to have value-based payment with health plans are a huge push. I mentioned, again, just understanding your population space, but in recent years, there's been an increase in digital health adoption across different populations. So you see the image here, talk space, neural health, something is even as more innocuous like Calm, that is now getting more adopted in the in the space of well-being. So how does that play in the larger picture? For an organization that provides services across complex populations, how does telehealth play in all of that role? And then you now have behavioral health companies that are popping up left and right, merging and acquiring. So here you see some examples of all that where, Amazon got into the health space. CVS, that's one would typically think as a store, is now getting into the space. So that's really changing how the behavioral health landscape. Thoughts, comments, Erica and Chrissy?
I was going to add one thing about whole person care. So the other thing that we're starting to see is whole family care. So if your organization provides additional services for children and adults, much like Pacific Clinics does, what we're seeing is, and actually the CEO over at Pacific Clinics says it the best, you can't fix a child and return them back to a broken home. And really we're looking at when you're doing that whole person care and those wraparound services, who else could be involved and how else can we have a better outcome? Because now we have a way to track the whole family care. The other thing that's happening is because we're trying to do this whole person care model, you all know this more than I do, the folks that are joining this call, is that you have multiple programs that have multiple requirements and they're all different and the workflows are different, and trying to get a system that you can run all of your programs in one place so that way you could do that wraparound care is the challenge. And so how the trends of the industry is going is we have to move to a place where we can actually do that wraparound care. And those were the things that I wanted to add. Anything, Erica, on your end before we go to the next one?
No, you said it perfectly.
Yep. So for organizations like, Pacific Clinics, where you're asked to do more with less, digital transformation is the only way to do it. I mean, it's a lot of effort, but moving to automation, moving away from the manual processes is really the only way to get more efficient and effective. At least that's, our belief.
And so some of the things that we're seeing that are highlighted here are this multi-channel approach. So it's no longer enough to just meet people in a physical space. It's not always possible. It's, or in an office. So if you are meeting them in person, it may now be in a school, it may be as part of a mobile crisis response, trying to meet people where they are, if it's in person or it's from their couch at home. And that's one of the things that's made mental health services more approachable and acceptable to a lot of folks, because we've broken down those barriers now with telehealth options of people not having the time, people not having the childcare, people not being able to get into an office during standard hours when they may have to juggle their work schedules. So being able to do that, the telehealth that Eleanor talked about, the ability to have HIPAA compliant messaging, a client portal where people are able to come in and, manage their own care, see their own referrals, some of the things we'll talk about later in some case studies, being able to use bots, for instance, to get answers to simple questions or talk to someone at a crisis line. All of those are, obviously phone as a channel that's been around for a long time, but all of those are new ways in which people are needing to access care. And that care from anywhere really ties directly into that, right? It's the same thing. I was once in an airport sitting in the boarding gate, and the person across the aisle from me was having a clinical, a virtual session with their therapist. I don't know that that's what I would recommend, but, that truly is showing that you could get care from pretty much anywhere. And I think that flexibility to change is a really big piece of this. So as technologists, we can do part of the work. But we all know that the people who have gotten into these fields have gotten into it because they love to help people and they love to interact with people. And so technology is oftentimes a burden, seen as a burden for them. So they've got to document their activities in order for the organization to get paid, right? Which is critical for you to be able to keep doing your work. But trying to make that technical change as easy on them as possible and reduce the duplicate data entry that's often a challenge, reduce the time that they have to spend in front of a screen so that they can spend that time with their participants is something that's key to that. But it also does require a commitment from the top of the organization. And I think that's what we've seen at Pacific Clinics that has made a huge difference in their ability to make these adjustments. And, those are ongoing, but the fact that leadership at the organization is committed to a digital transformation and is messaging that both from a benefits perspective and a, inevitability to their staff is key to making this work. Eleanor or Chrissy, anything you'd like to add to that?
Yeah, no, I mean, you're absolutely right. I mean, thinking back to that quintuple aim, right? This is how we help with the clinician's well-being. If they don't need to be thinking about a lot of different things or memorizing tasks, going in and out of different systems to get their jobs done. If the workflow for them is easy, that's one way of minimizing stress for them. Making sure the system is designed again to support their day-to-day workflow really helps with addressing clinician well-being. From our consumer standpoint, having access to their information, knowing where they are in the process, without having to call people, being able to communicate through these multi-channel approaches is huge in changing their experience and affecting their experience. And in today's market where you have to really truly market yourself and, to say why they should choose you over a competitor, having these digital experience where it's efficient and easy is important. And again, I mentioned reducing costs. While this implementation and the initial cost is costly, it does cost. We think the return on investment is worthwhile. And again, it's getting access to more people, which is what we ultimately want to be able to manage population health.
Yeah, I'll just add kind of my own personal journey on the flexibility to change. So my experience trying to get my child help was painful. And I'm in Oregon, so not Pacific Clinics. I had to print off documents, fill them out, find a scanner. Like today's world, I don't know who has printers at home and scanners, maybe some of you do. But it was very difficult to get my child care, and every day the clock was ticking, and every day his education was being affected by that. And keep in mind, I am someone who I work, I have access to technology, and I'm thinking about these families who don't have the same access that I have, or a single mother who now you're asking to go find a way to print off a document to then get it to the organization. So flexibility to change does improve the consumer or the client's experience, and it just makes the access to care faster. So when we start getting into equity of care, that could be one area there that we could focus on. So from a consumer's experience, that flexibility to change does make an improvement on what that experience is for families. So I just wanted to throw my 2 cents out when you guys are thinking about ways you can improve it.
Yeah, and that's a great point. I mean, a lot of families were relying on, and not just for mental health services, right? But to get their kids into school, get them into a Head Start program, had relied on people coming in and filling out those that paperwork in person. And with the pandemic, we saw that that wasn't possible, and it kind of gave an opportunity, in many ways, that was an opportunity for people to think differently and have a paradigm shift, and that maybe some of these things don't have to happen in person. And as I said before, that really does increase equity, because it's taking those people who may not be able to have the job flexibility to take off during the middle of the day when the office is open to come in and file their paperwork, or not have that access to technology that Chrissy spoke about, and making those services more accessible to them.
Yeah. And just from if you can imagine just having to write your name once instead of, I don't know, by the hundreds with every form that you sign. That's a small example, but a huge impact.
Yeah, I'm glad you brought that up, Eleanor, that piece. And then we've also heard from other organizations, especially when they're doing like domestic abuse or sexual abuse, they have to relive and tell that story over and over and over again, because they're working with different people within the organization. So if you have a platform or a technology where, based on HIPAA rules and who can see what, they can share the information that they need to do to collaborate and really provide that care that they need. So I'm glad you brought that up, Erica. That's a good point. Okay, we'll go to the next one. So we're going to start getting into some case studies on work that has been done. So I'm going to let the team take it away.
Yeah, and I would say that before we do that, just do remember that the chat is here. So if we want to keep this really conversational, so if you have any questions now about anything that has been talked about to date before we get into the case studies, please throw them in there. Otherwise, we will get going and we'll take questions as we go. But again, just want to keep this really interactive. This is for you. So
should we give a minute to see if anyone can?
Yep.
Or we can give a minute.
I think we could.
Too bad we don't have any Jeopardy music to play, but
and I won't start singing.
I'm not seeing anything in the questions or in the chat, so I'd say let's carry on.
Okay.
All righty. Okay, we're going to talk about, I've got 4 primary case studies today, but as I said, we at Provisio do this across the country, so there's a lot. It was hard to narrow it down to 4. These are examples that are specific to Pacific clinics, but if you've got other questions, ideas on what might be possible, it's very likely that Chrissy or I have seen that use case elsewhere. So we're going to talk about school-based intervention, mobile crisis, drop-in center, and then that CalAIM ECM and community supports that Eleanor spoke about earlier. I think it's important to note that as Pacific clinics embarked on this digital transformation for them, Eleanor, as she noted, her charge is new business. So she was really frustrated with the pace of change and the fact that she wasn't able to quickly adapt to bring new programs to Pacific clinics. And that was really what led her to Salesforce, because she needed something that where we could get some of these programs up and running very quickly. And so we've been able to do that. Sometimes these programs are still kind of in development when we've been working on bringing them up on the system. So we're all kind of learning and growing together. But we've been able to forge a great partnership and are able to pivot as needed. And that flexibility of the Salesforce platform has really been key in enabling them to grow in the way that they want to grow. So we're going to talk about school-based intervention. Eleanor, do you want to talk a bit about the program and then I'll get into the problems that we solved?
Yes, so our school-based intervention team is basically a framework for how we deliver services in the schools. One component of it is direct services, so direct services to the students. The referral might come from a teacher, the student themselves if they want services, administrators, the parent, but the key here is that it's direct services to the students in the school setting. Another component, there are 4 components. The second component is training and development. So this is, pre-service or in-service for teachers or anyone else. The third component is your community component. And so, how do we work with the schools who are the hub for many of the communities? Family resource centers, wellness centers are huge terms that are coming up. Or I should say is a trend. Again, it's how do you wrap the community with the schools being the hub? And then there's all the other components that supports the school. So McKinney-Vento, for example, how those are dollars for students that are homeless. How do we wrap that around, if you will, so that we can support a child, not just through because of their behaviors in school, but everything else that might be affecting them in school. So there are 4 components there. And what used to happen is, someone in the schools would call someone on our staff, and then that person, that staff member, would then let staff member B know that there is this referral. Staff person B would then need to reach out to the teacher, the student, the parents, to then coordinate just that first meeting. And that was all done manually. So we hope that when that first referral comes to staff A does and communicates with staff B. But you know what? Sometimes in the school setting, they forget or they write it down, and it takes a couple days to get back to them. So there's that manual process where I imagine we would lose a lot of people. And if you're a person in the school setting who's trying to get the students some help, and it's taking days for a response, when every day is a long day for the student as well as for the teacher and administrator, then that's not helpful for anyone. So that's kind of the problem that we wanted to solve. We wanted to make sure that it's efficient, for people to attract service, to refer. The other thing about our school-based program is that we provide education services throughout the state of California. So one of the other things that we wanted to address was how do you streamline the referral process so that we don't need to have 18 call centers, if you will, or a point of access in the 18 counties in which we operate. So again, this is an example of how we use technology to really streamline that. And we call that our call center, our concierge center. But I'm going to turn it over to Erica to kind of show how that referral process and the call center was developed.
Sure. And so here we're just seeing some of the things that, we heard when we spoke to that school-based team. And we're going to talk today about a teacher. Her name is Paula, and she has a student in her classroom that is having some behavioral issues. So she wants both, she's reached out to Pacific Clinics, who has a contract with her school, and she knows this. So she's reached out to both get help for the IEP that she's prepping, but she also would like someone to come in to her classroom and model some interventions that she can use with the student. So what she's done is fill out an inbound form. So we have several different forms that are on available via Pacific Clinic's website. So they are able to, people who visit the website are either able to make a referral for that patient, for that child. That can be, as Eleanor stated, a self-referral. Parent can make a referral on behalf of their child, or a teacher or administrator is able to make that referral. And then they can also have a form by which they can request professional services or in classroom services like I described. So that is all live today, and it's really increased the ability of that team to respond and both to track what those requests are and make sure that nothing's falling through the cracks, as Eleanor stated.
And I might add, our school-based program grew by 300% in the last 2 years. And this has, one is part of the reason for, this automating and automating our process, but also I anticipate that this will also further grow our program.
And I'll throw one thing out for folks that are brand new to Salesforce. So our technology is mobile friendly, and yes, COVID kind of changed things to be more virtual, but now we're seeing people getting back into the field. So should a teacher or a staff member be out and about, they could access the Salesforce records, workflows, forms through a mobile app as well. So that's why we wanted to show that mobile screen.
Yep. And right now, we're in the midst of the development effort for the school-based program. Right now, those teachers and administrators can submit that form. But we're also working on a portal for them where they will be able to log in, create their own account, and then they'll be able to go back and see exactly, what the status is of that referral. They'll be able to have a secure conversation with someone at Pacific Clinics about that particular referral or case. So you're not having to worry about faxing something or sending an encrypted email that someone may or may not be able to open, or worried about texting and trying to use acronyms or, codes to be able to identify the student so that you're not breaking any HIPAA considerations. So that ability to have a secure place to chat is something that the team is really looking forward to. And it's also going to be a secure way to exchange documents. So if, for instance, they want that teacher or someone at Pacific Clinics to review the language in the IEP that they're prepping for that meeting, they're going to be able to upload that. No one's going to be able to see it except those who are authorized to do so. And it's going to really facilitate that communication between the educators in the Pacific Clinic staff.
One last thought to throw out. So speaking of IEPs and seeing this, you're going to see how many days open. So when you're working with, I learned this from Eleanor, there is a clock. So when a parent needs services, I need services, and I am guaranteed services within, I think it's 45 days here in Oregon. So what some of our customers are actually using is once that referral hits the platform, that clock, how many days open, helps to kind of make sure we're hitting those timelines. And you can put workflows within Salesforce that alerts the caseworker. It alerts management to let people know that we're on these timelines. And let's say it was me that was holding it up because I needed to sign consents or forms or documents. That alert could also go to myself because I now have that task to keep the thing on schedule. So just as a heads up, when you're thinking about how you would create your workflows of things that are holding up your team or things that would streamline it, that's how we could leverage that. So I will go to the next slide though.
All right, great. And so we kind of hinted at some of this already, but some of the things that are going to be included that are, ways that technology are helping the school-based intervention team or may help them in the future. Those referrals for counseling services, we already talked about training requests, that HIPAA secure messaging, having portals for parents and guardians so that they're able to communicate and fill out those consent forms, as Chrissy said, or upload medical records or something else that the team may need. And then that portal for teachers and staff, they're able to, as I said, see what the status is of those referrals or add any additional information that's needed. It's also a place where parents or guardians, if they are making linkages, so if that team's making linkages to other services, or when we talk about kind of getting ahead of ourselves, but talking about that whole family care model, that's where, if they need a referral to a food pantry or any other resource, it's not just carrying that paper out of the meeting that they may lose. They're going to have a secure place to come in and have all that information. Oh, these are the places I was referred to. Here, I can see them on a map. I can, click to call if I'm on my mobile phone and looking at this. So all of those are going to be key pieces. Also, another thing that's up next, that's under development, is that call center or concierge center that Eleanor spoke about. So this is a place where people will be able to call, whether that be the teacher, the administrator, a community member or consumer. They're going to be able to get brief advice on the phone. So the people answering the phones are going to be trained to provide some brief services. If they either can't have that conversation right now, or the staff isn't available for that, they're able to make an appointment. So they can either do that immediate or by appointment. They can get an in-person crisis response. And this is really important. This is an important service that the school-based program offers, is that if there's a crisis going on in that school, someone can respond. Some of the schools have a level of care that they've got someone on site full time, but that's the exception rather than the rule. Most often they have somebody from Pacific Clinics that's there part-time, or they just have it by appointment. So Pacific Salesforce is allowing them to see where all of their clinicians are at once. Oh, sorry. Be able to see where all their clinicians are on a map, see who's closest and available, and dispatch that person. So if it were Chrissy, say Chrissy's in the school that's just down the block, right? And there's a crisis, and we can see that Chrissy's there. We know her schedule. So if we know she's available-ish, she might be in the middle of something, but the crisis can take priority. And we can send Chrissy a message. We'll assign that to her. She'll have a mobile app on her phone. We'll see that in a little bit in another case study, but she'll get pinged that she needs to respond to that crisis. All the information, background information she needs is right there on her mobile device and available to her, and she's able to respond really quickly. So that's going to be a huge increase in the ability to provide those services. And then the classroom modeling that I talked about earlier. We're also looking towards the future with virtual consultations that are HIPAA compliant and have like that exam room concept for the provider team. So
if you can just imagine, you in a brick and mortar, you might bring in different people, whether it's your PCP, your behavioral health staff working with parents and the kids. Just think about being able to do that same functionality, but virtually. And that's some of the innovation that, we hope to build.
Do you guys mind if I bring up, well, I'm going to bring it up. There was one of the projects that they worked on. The team also got a list of referrals, right? So they had hundreds, was it thousands? Hundreds of
Thousands.
oh,
thousands.
That's Callie. Yeah.
That's coming up, Chrissy.
Okay,
We've got it.
all right.
That's case study number 4.
Okay. So before we go to the next case study, though, there was a question about HIPAA and sharing information, especially before they're a client. So each organization is different. So if we're talking about, there's different products at Salesforce. So first, I would say, if you're trying to explore what would work for your organization, please reach out to your account executive. They'll pull in someone like myself, which is a solution engineer, and we'll help kind of figure out what products to put in place for what use case. But specifically for HIPAA and like EHRs and healthcare. So typically what happens is Salesforce will run the kind of the process around the client, and then we can connect data back and forth to an EHR. Most organizations are still required to use an EHR because of meaningful use and billing. So we'll be able to connect the data that you need to, and in each customer, it's different. So some customers want to pull a lot of their EHR information into the Salesforce platform for other use cases. Some just need something like a diagnosis or a code. So we'll work with you on whatever that may be, but we can connect to EHRs as long as your EHR has an open API. But please connect with your account executive. Reach out to myself too. If you just want to shoot me a quick note, this is how we work, and we'll help you figure that out, but it can be done.
It was the question, how to be HIPAA compliant before treatment?
It was connecting to an EHR. And if I am misunderstanding that question, because I went back to try to find it, disappeared as soon as I said I would answer it. Please feel free to come off of mute or chat again. But from my understanding, it was how do we kind of integrate with the EHR, especially if it's not a client. But know that our platform is HIPAA, allows you to be HIPAA certified. So you can still do that and do roles and responsibilities, encrypt data, audit trails, those types of things. Okay. Pause for a second if there's any questions. Otherwise, we'll go to the next case study, which is one of my favorites. Okay, we'll go.
All right. It's one of my favorites too, Chrissy. So, mobile crisis is something that we touched on earlier, but Pacific Clinics had been offering mobile crisis for children in Santa Clara and Solano counties already, but a new initiative that they started is Trust. So Trusted Response Urgent Support Team. The focus of Trust is on individuals experiencing homelessness in Santa Clara and Solano counties in California. And the idea is to reduce the level of response needed by law enforcement and instead have a trauma indicated clinical response. So Eleanor, if I misspeak on anything, please.
Yeah. So this is
why don't you describe it? That's
Yeah.
probably
No, you did great. And that's why they're a great business partner, because she can speak for me. But yeah, so Trust is in Santa Clara County. It is really, a component of the larger picture, with 988 being implemented. Trust was a mechanism where you would have various, a team that would be in the community, so that should there need to be any response, this would hopefully decrease the need for law enforcement intervention. Particularly, in communities where there have been challenges in the relationship between the communities and law enforcement. This is really a way to be able to address some needs in the community in a manner that, again, would decrease law enforcement.
Yeah, and the great thing about this is when this van is staffed, Eleanor, by 3 staff people, right?
Yep. A clinician, a peer person, and I forgot what the third person is.
It's a medical professional, but I know that there's been discussion about the level of person. That's why I didn't want to, but somebody who can administer basic medical care. So question about whether they had to be an EMT or not. So I'm not sure where that landed, but the idea is that while they're not responding to a crisis, they're out in the community forging relationships with the population. They're doing things like passing out blankets or sandwiches or providing basic first aid, things like that. And then if there is a crisis, they're able to respond really quickly. And the reason that they're able to respond really quickly is because they're using Salesforce Service Cloud and field service. So again, like we described for the school-based program, this is using field service to be able to track the locations of these vans, allowing them to not just be sitting there waiting for the next crisis to happen, but to be actively engaged in the community. But yet when a call comes in through 988, that's then routed to the Pacific Clinics team, they're getting that call through Service Cloud Voice. They're picking up that call. And if the need is to dispatch the Trust team, which it isn't always, right? There's other interventions that can be done just via the phone occasionally. It's not always the case that someone needs to be dispatched, but if they do, they're able to use that field service app. And I think I have a screenshot in here, Chrissy. Oh, here we go. So this is kind of showing the overall architecture. So we've got that incoming call that's either coming directly, because there is still a Trust line, but it could be coming through 988 as well and transferred from there. The call center staff is using Salesforce Service Cloud to triage that call, to provide immediate crisis support if they're able to over the phone. Like I said, if that in-person response isn't needed. And then they're able to dispatch. So Trust is the thing that we talked about. But as I said, Pacific Clinics had already been offering and continues to offer crisis response services to children in Santa Clara County as well. So it may be the case that, depending upon the situation, that either the Trust team is dispatched or that MRSS response team is dispatched. In either case, that dispatcher, the person who answered the phone at the call center, they're going to be able to pull up a map and see exactly where the people who are available to respond are. So that's what we're seeing on the left-hand side. This isn't the map view, but this is showing all of my service resources, they're called, the people I have available to respond, what appointments and availability they have. And then you're able to choose someone to dispatch to that location. And then on the phone views, you're seeing what the person being dispatched or that service resource, that trust fan out in the field is going to be able to see. And they're seeing that they have an appointment. They're seeing exactly where that appointment is. And as you can see, they can click that big button in the middle to get directions. And then it's going to move right into their mobile capabilities and give them, use their map of choice and give them directions. One of the features that is incredibly cool about this whole thing is we're also using something called, oh, I don't have a picture of it yet, Chrissy, but we're using something called Appointment Assistant, where when that person is dispatched and they're on the way, the call center staff can send a link to that parent, that individual, so if it's a child in crisis, the parent who called in gets texted a link, and that link is one that they can click on to see where the person is that's en route. So imagine the peace of mind, not just knowing that someone's coming, but being able to see in real time where they are and how close they are, like you can when you're waiting for your Uber. So that's really going to, we think, improve the experience for those consumers who are in crisis and desperately waiting for help.
Yeah. So prior to all of this, let me just kind of give you an example of what our mobile crisis team, how that worked. Call would come in, to our central number, and our staff, literally whoever was managing that call, would actually literally page the staff member that would go out. So whoever was on call for crisis services, they would get paged and then they would get deployed. On average, it took 37 minutes, to get someone out there. We're hoping to decrease that time, but with things like this, people, can again get a better understanding of, when and where their help might be. And hopefully we move away from the days of pages.
The other thing to throw out is we've talked about scenarios and with other organizations as well, is when someone is in the field from that mobile app that you're seeing right here, they're doing what they need to do, what they've been tasked to do, but at the same time, they could do like an evaluation, or they could log a referral to another organization because it's all connected to that Salesforce platform. Again, we're starting to integrate the different teams if needed. You could separate them, but if you do want to do a warm handoff, like, hey, I talked to this person, I think they would be a benefit of this program, so I'm just going to make an inbound or an internal referral. You could as well.
Yeah, the other thing that's key to note is that they're able to get you'll see that at the top there, we've got the overview with the map, but there's also like the details tab, related tab, feed. So all of the information that was collected by the call center staff, and we can't click on these, they're just screenshots, but they can be connected, or, they're instantly available to the person in the field. So they're not having to, to Chrissy's point before, making someone who's, in a crisis situation retell their story is not something that we want to do. So they're able to have the access to all that information. Before, a lot of that was happening via text, back and forth, and trying to use code so that the text would be, HIPAA compliant and we weren't giving anything away. So that's been, that level of communication and knowledge so that the person's coming into the situation well prepared for what's ahead of them is going to be really important in their ability to respond. The other thing is that we have been able to embed their consents right in the app. So when they get there and someone has to consent to services, they're able to see all of those consent documents and electronically sign them directly within the app. So that's really streamlining that part of the process as well.
Yep. And then at the end, we get to send out a link for a satisfaction survey.
Mm-hmm. And are able to note all of the, as we said, if this is a clinical encounter, they're going to want to take those notes in their EHR. But in the meantime, what they can do is take, we've enabled them to create a draft note in the app. So that draft note is going to really help them when they get back and have time to document in the EHR. And they can even use voice to text capability to do that. So while they're in the field, they can just, it's a text field. So just like you do when you're making a text, you can click the little microphone button, just start talking. It's going to put that all in. You've got a great start that you can copy and paste into your EHR for that case note and continue that documentation. All right. So any questions about mobile crisis? We'll pause for 30 seconds. All right. The drop-in center at Pacific Clinics is actually one of the first programs that we implemented. And the reason for that is they are a non-clinical program. So the EHR was really not a good fit. They were using the EHR, but it wasn't a good fit for the types of services they were offering. Eleanor, anything more on that, on the problems before I get into the solutions?
Yeah, so let me kind of give you a concept of, the drop-in center. And it's a drop-in center for transitional age youth, so your older teenagers, young adults. And it's based on, for those of you who are clinical, based on the principles of motivational interviewing and recovery supports principles. We wanted to create the space where, these individuals who might need services or might want services in the future, but are not quite sure if they want services right now, they could come in. It would be a welcoming space. We had a section for them to do, a section with computers where they can do all sorts of searches, maybe look for a job, whatever the case might be. We had a washing machine and dryers there, so that if they wanted to do their laundry, if they're homeless and they have, someplace to do that, we had a kitchen for them. So it was really, this is not treatment, but there was no other way to capture how that space was being used, who was coming, what services were they accessing, short of, entering them in the EHR, which would then make the process very clunky and it would actually de-incentivize people from using the system. We wanted to make sure we had a way to seamlessly gather information without people even thinking that they're gathering data that would lead to bigger and better things. So that's kind of the concept here. I mean, it truly is based on, if someone comes once, they come once and they're now a lead in our in our system. If they come multiple times, then, we can see who they are and what they use. And if they decide to go into treatment, guess what? That data now goes into our EHR. We never have to enter that information again, the basic demographics. It's there. And the team who's now working, the treatment team can now see the history of the services that was used prior to coming into our, more formal, if you will, treatment services.
Yeah.
So
So to solve those problems and those challenges that this team was having, we were actually able to use nonprofit cloud case management. We stood this up really quickly. It was the quickest thing that we implemented because nonprofit cloud case management, takes care of so much of the heavy lifting. But we were able to just create a very simple intake form for them. The idea was not to create any barriers to entry. So they collect very minimal information about the kids coming into the drop-in center. But we were able to create that intake, be able to enroll them per se in that drop-in center to know that they've, when they started that relationship with Pacific Clinics in this way, and then record those services. So as you can imagine, it's important to know how many people they served, but also how many people take showers. Is there a trend in when people want to do laundry, right? Those are things that are important to know so that you've got enough laundry soap, right? Or maybe you need to buy another washing machine. So making sure that they were able to track those things just to be able to monitor capacity and know kind of what the trends were. As Eleanor said, they also have now that information both for outreach. So they've got that person's email. If they have gotten consent from them, they can send them information about new things that are coming. If now we're starting to offer a hot meal on Tuesdays or whatever that may be. The other key piece for that drop-in center team was the ability to track groups, because they do have a lot of group activities as well. So with NCCM, you're able to track individual activities that, Eleanor came in and did some laundry and took a shower, but you can also track that we had a, support group for, I don't know, Eleanor, give me a good example.
Or like, a skill building group. How do you
Right.
present yourself in an interview?
Yeah. So if they've got skill building and they've got that every Tuesday night at 7 o'clock, they can set up that schedule in Salesforce as a service session, and then they're able to just record the attendees really quickly and easily every week when that session's happening. So it's really gone a long way towards easing the documentation burden on the staff of the drop-in center, while being able to give them the rich data and reporting they need to think about the future of that program and what it might hold. And then they can also take notes on, on the right-hand side here, it's showing the ability to take a client note. These wouldn't be clinical notes, right? They're not in treatment yet, but if they just wanted to record an interaction so that it's available for the rest of the staff, so that they know that, Maria's going through something right now that they want the rest of the staff to be aware of, they can do that.
And then I'm just going to call out a few things about the case management product. I did put a link in the chat if anyone wants to learn more. But while Pacific clinics may utilize it in this form and fashion, just keep in mind that the platform, the Salesforce technology, is flexible and it is customizable. So if you need different fields when you're taking a note because of reporting or requirements, we can add those in there. You can tag things. And then when you're ready to actually create the notes and you maybe need to report it to a funder, you can filter out all the notes. So if there's a client receiving multiple services, but you only want one kind of grouping of those notes, we can actually kind of slice and dice it, and then you can print it out for funders. So that's one way we can be flexible. And then on the left screen, when you're doing that intake or that enrollment process, if there's different checklists or items that you need, you absolutely can adjust these so that way each intake, so because each team may have a different one, you can actually put what you need. The benefit, though, I'm going to call it out one more time, is because it's a shared platform across teams, is if I say that there's 5 programs and we need to collect client info, what we can do is surface the client info on that screen, which has already been gathered from another team. And we're simply saying, hey, did your emergency contact or your address change? And if so, on that screen, they can update it, and then everyone else has that update. So we're really sharing that data. We're reducing data entry, and we're just streamlining it as much as possible. Should you do a portal as well, and Erica and Eleanor, you kick me off, but should you do a portal as well, if you open that up to clients to actually put in their emergency and their contact information, they're doing the data entry. They're making sure that it's up to date. And now your team just has the most recent information. So you can streamline it across the board. I will stop talking now. We can go to.
And
yeah, go ahead.
yeah, I would say that, for organizations that many of you are from that probably are offering mental health services, as well as a lot of that whole family care, other whole family care services that we're talking about, there are, those things that wouldn't be in your EHR. These are, NCCM is a great way to capture that information, not just for the individual, but for their whole family. So we can have family level services. You can do non-clinical case plans. So if you want to set up goals and action items that are relevant for that person, whether they're looking in a job training program, and those goals are things like obtaining a GED, and then having 10 interviews, taking a job readiness class, and then eventually getting that job. Those are the types of case plans that you could very easily use NCCM to set up, and those are also available through that portal. So if you want that consumer or client to be able to track their own goals, check off their own action items, things that they did, that could all be available to them through that portal as well as that secure communication with their care team that we talked about earlier. All right. And this is the one Chrissy tried to hint at earlier. So Eleanor talked about CalAIM a bit, but Eleanor, you want to give everyone a little more background on it? If they're from California and in this space, I'm sure they're well acquainted, but if they're not, they may need an intro.
So CalAIM, is a multi-year initiative, again, to basically transform how the population, the Medi-Cal population receives services. And we're talking about 14 million people in California. Prior to CalAIM, there were a couple of pilots. One was the Health Homes program. And so Pacific Clinics actually participated in that pilot to see, what we needed to do to be prepared for CalAIM. And right now there are, two basic services that are now being administered through the health plans: enhanced care management, ECM, and community supports. Community supports have a number of different services within them. So housing is one example of that. Transition from nursing homes, long-term care facilities is another example. Medically necessary meals, those kinds of things are all example of community supports. But for us, enhanced care management and community supports was in effect January 1st. The process for us didn't change a whole lot, but it did have an impact. Even though HHP, Health Homes, was a pilot, that really did prepare us and help us to understand what we needed to develop for enhanced care management. But let me give you an example of what happened every month and what continues to happen every month. The health plan give us names of members who might be appropriate for, I'm just gonna say, for ECM. And our staff then need to reach out to these members. For us, we are across multiple states and across multiple health plans. So we get names from a number of different health plans across all these different counties. Every month, they would give us a list of members that had many, many columns and many, many rows. It wouldn't tell you who was new. It wouldn't tell you, and the names wouldn't drop off. So every month we had staff that had to go through the list in an Excel spreadsheet to see if they were entered into our EHR. And if they wasn't entered into our EHR, then they would highlight that person's name, and then we would have staff call them. And so every month we would go through this. That one process with one staff would take 80 hours. So half the month would go by before we could even do anything, to meet the client's needs. And then on the fiscal end, we wouldn't get paid until they agreed to be a part of the service. So you're incurring costs for staff to be investing their time in sorting through Excel spreadsheets until, they could find who of the thousands of names they should be calling. So that was a process that was then, and I'll turn it over to Erica to say how they've kind of helped us solve that problem.
Sure. And not only were there files that were, would keep growing over time, because as Eleanor said, no one dropped off. So maybe you had, in a simple world, maybe you got 100 referrals the first month, 100 new members identified the second month. Now your file's 200 people long, and it's just going to keep growing and growing and growing because no one's ever dropping off. So all of your current, former, and future members are included in this file. Every health plan has a different file format. They have different data points that they're tracking, and they have different formats. So some of them are CSV, some of them are TXT files that are pipe delimited. Almost all of them require that someone physically log into their portal and download the file. And you can see that, when we're talking 80 hours, that was with one health plan, Eleanor, or two? One. So this is a program that Pacific Clinics really wants to be able to scale, right? And there was just no scalability when we were looking at that. So we proposed and are using MuleSoft to be able to facilitate this processing. So MuleSoft is able to do all the decoding for us. So because again, not only is it different data points, it's in different formats. So the county may be a county code in one case, or it may be the name of the county in another case, as an example. Diagnosis codes may differ. Even some of the files are 3 files, some are 1 file. So it really all varies quite broadly. So MuleSoft is able to process all of those files and get them to one consistent format that is consumed by Salesforce. So MuleSoft sends the consistent format to Salesforce. Salesforce then tries to match it against an existing member. So one of the things we do have going for us is that there is their Medi-Cal ID number is in all of these files. So matching is not the problem that it sometimes is when we're talking about a situation such as this one. So we're able to match if that person's already an existing member. We have a process, because the other challenge is that sometimes the health plan will have new information about an individual. It may or may not be the most current information, because if in the case that Pacific Clinics is actively working with an ECM member, they may have a better phone number for the person, right? And they didn't want that information to be overwritten. So what we're doing in the case of a match, right? So if we find that someone's already in the system, we're comparing every single data point against what we got from the health plan. And we're actually displaying on a screen which data points differ and allowing the user to select which ones they want to update. Obviously, there are certain things that are pertinent to billing that are always updated. So we're selectively displaying those that are optional, where they wanted Salesforce to be the system of truth, and we're allowing to update really quickly. Now they can very easily have lists. Once this is done, and it takes I think 5 minutes at the most. Once this file is processed, they now have lists that they're able to do outbound calling. So they're using Service Cloud Voice. They've got an integrated phone system. They now have, within minutes, they've got a list view in Salesforce. They're able to just go down that list and click on that phone number to dial, and it's made the entire process far more efficient. That's automatically recording those phone calls because of the integrated telephony solution. It's automatically recording those phone calls as outreach attempts. And they're able to add information to that in terms of what the disposition of that was, right? Did they get a voicemail? What were they doing? And then we also have the ability for them to send emails directly from the system using some pre-built email templates. So if they've got, the phone number is not working and they're unable to reach someone by phone. And we've also created some workflows to make things easier for them to send snail mail out, or to track sending mail out as well, because if they're unable to reach someone via phone or email, they need to try to reach out to them via standard mail. So we've got some things that we've built in for them, so they're able to print that report that gives them all that address information that they can merge into documents. But then it also, when they do that, tracks those outreaches, so they're not having to manually enter those. So that front end of the process has really improved. Then on the ECM side, once that member decides to participate in the program, that's a clinical program. So the rest of the information needs to be done in the EHR. So Pacific Clinics uses Welligent, which is an on-premise SQL-based EHR that doesn't use Fire connectors, and nor does it have any available APIs. MuleSoft has enabled us through something called ODBC, or Open Database Connections, from MuleSoft, despite the fact that there are no open APIs for Welligent. Because they have that level of access to the database, we are able to, once that person converts or decides to enroll in the program, we're able to push that patient directly to Welligent and create a patient record in Welligent with all of the supporting tables. We're not talking about a single table here. We're talking about 5, 6, 7 tables. I forget how many. So that's in final testing right now. It's scheduled to go live very, very soon. And I know that is going to make that team incredibly excited to be able to just, once that person, every night, it's going to be a nightly batch because that's all that was needed in this case, although it could be real time as well. Every night, all the patients that, all the members that enrolled will be pushed to the EHR, and they'll be able to start documenting that activity for them starting the next day. We're also going to be using the MuleSoft to connect to their billing provider. So Pacific Clinics is using a third-party billing provider. We're right now giving them reports and they're doing that, but we're looking to, as they, because this is a new program, as of January 1st, not only is Pacific Clinics updating their technology, the health plans are updating their technology. So there's been a lot of flux in terms of values, billing expectations, KPIs, all of those things have been changing quite rapidly. So we're waiting to get to kind of a consistent state before we build that integration, but that is to come. And then in the middle, which I kind of skipped over, that community supports program is those wraparound services that Eleanor spoke about. So that's about getting people connected to things like medically tailored meals and other things. The focus of community supports from the Pacific Clinics perspective is on housing and getting people housed. That's expected to grow as the program grows. CalAIM is a phased multi-year approach. So housing, being a critical need is one of the first focuses of the program. So that team in community supports is able to track that non-clinical activity in nonprofit cloud case management with all of the features that Chrissy and I talked about before. So the ability to note that they're engaged in the program, take notes on their interactions, record their outreach attempts, and then record their service deliveries. And the service deliveries are interactions in the vernacular of the program. But the health plans also have different delivery models and different payment models. So Salesforce and NCCM are flexible enough to accommodate that for the different health plans while providing as unified as experience for the staff as possible. So they're not having to think through, oh gosh, this is Anthem, so I have to code it, I have to do it this way versus this is Centene and I have to do it a different way, or HealthNet. So it's helping them through that process, and it knows what's appropriate and what can be done based on that client. And then, of course, a key part of especially the community supports aspect of CalAIM is the ability to provide linkages and referrals. So it's also allows them to track referrals made both within and outside of Pacific Clinics. Did I miss anything, Eleanor? Nope.
Sorry, nope.
I
I just love the fact that you can talk about the programs. Again, it just illustrates our true partnership here. I mean, we can complete each other's sentences here with Chrissy.
I'm actually shocked that no one asked this question in the chat, because I always get this question when we're talking about like connecting with MuleSoft or data exchange. How can we do like an audit trail or track who's changing what, the prior value, just in case? So there is a way with field history tracking within Salesforce that will be able to log, okay, this person changed this value at this time. So if you ever needed to record that or note that, you could. So that is there. And then there was a question in which Meryl answered, but it was a great question. So how is the client portal integrated to Salesforce? It is built in the Salesforce platform. So when you think about your team, they'll be using all these records and they can access the fields. And what your team can do is then say, well, we want our clients or our parents to see record A, C, and D, but we don't want them to see B. And they can see 10 out of the 100 fields. So you all get to control what they can and cannot see, but it's the same platform. So this is really great for IT folks, because you don't have to worry about integrations. It's just creating those roles and permissions of who can see what. So it's really great. One thought on that too is if anyone wants to kind of play around or work with Experience Cloud, especially if you already have Salesforce, you could spin up a guest portal. So there's no authentication to start kind of seeing how those work. And then of course, if you ever want to go deeper in any of these things that we're talking about, case management, MuleSoft, portals, again, reach out to your account executive, reach out to myself, reach out to Erica over at Provisio if you want to. We're all happy to help, kind of all the same team. So doesn't matter who you reach out to. Okay. So we are going to do one last poll because we're going to transition to the last topic, which is how do you get started? So we understand the industry, we understand the challenges and how the technology can help, but how do you get this ball in motion? So if Meryl is ready, I'm going to have you post that.
I am. So yeah, lots of great case studies and ways that technology and digital transformation can help you deliver better services. So the question is, what's holding you back? So we'll watch as these answers come in, and then I will be happy to share.
And then Chrissy, there was a question in the chat that I could take while we wait for those answers.
Sure.
Now.
That'd be great.
It was that one of the things holding you back was the fact that your EHR doesn't have an API. MuleSoft, it depends on your particular situation. So it's can't help in every situation, but in the case of Pacific Clinics, because Welligent was an on-prem, we had ability to get to the database. So we are able to write those APIs ourselves. And the great thing about this is the reuse. So this is the first use case in which we're creating a patient record, but once we've written that, kind of create patient API in MuleSoft, the next time that we have a program that's going to want to create a patient in Welligent, which I assume will be probably like next month, we'll be able to reuse that to, perhaps use different fields on the Salesforce side and call it a little bit differently, but we'll be building out that flexible create patient API, and then we can work through additional APIs as well as the use case dictates.
Thanks, Erica. It looks like we've got about 95% of the people in, so I will share the results.
Perfect. So we'll get into those. Overlapping priorities and budget, I would agree, is probably the most common one that I see. So we will start getting into how we can help you with that.
The other thing too is I posted it incorrectly. Chrissy pointed out to me that I posted something during that conversation that I only posted to the host and panelists, but I want to post it to everyone. And it's a shameless plug for the Dreamforce session that Eleanor and I will be doing on the CalAIM use case and case study that we just talked about. So if you're able to go to Dreamforce, we'd love to see you there. And if you're not able to attend and are watching online, check out our session.
Thanks, Erica. All right. So when we're talking about that digital transformation, there's kind of three areas that a lot of folks will focus on. I'm going to let Erica and Eleanor take this, and then I'll kind of throw in my pieces that I've seen on my end.
Yes. So, the question about budget and priorities, I mean, that's definitely a key issue. And I would say Pacific Clinic struggled with this for a long time. We knew, we needed to work smarter, not harder. But we didn't know how to work smarter and not harder. We knew technology could help us, but we really didn't know what technology could help us. So we struggled with that question for years. And I would definitely say, Erica mentioned leadership, and it truly is leadership. You're absolutely right. When there's a whole lot of priorities, it's hard to prioritize something like this. But for us, the risk of not doing this, the risk of not investing in this transformation, which was far greater than, not doing anything at all. So our CFO, a couple of years ago said, we are going to have a distinct department that's new business. And we're going to resource new business very differently from our core business. And so that wasn't an explicit decision, right? Because otherwise, before that, and this was part of my frustration, everyone agreed that we needed to be ready for CalAIM. Everyone agreed, that we needed to work smarter, not harder. Everyone conceptually agreed with all of that. But when it came down to resources, meeting the current business needs was always outweighed than the business needs. I mean, the new business needs. So anytime I needed something in our EHR, and we had a matrix that even said new business was important, but in that matrix, new business, my task would always get on the bottom. And again, this has nothing to do with people not liking new business, not us not liking each other, but it just, when you have to, when you're trying to figure out, when you're trying to use the same resources to do this transformation, it inevitably just, gets to the bottom. So we made it an explicit decision to have new business very separate, and to have the resources very separate, to build the infrastructure that's very separate from our core business. So that, again, yes, it's investment and yes, it's money, but, I think money well spent. I don't think we would be able to grow with CalAIM to the extent that we have. We had in our ECM program, our HHP program, we had about 300 patients by the end of 2021. We're close to 1,000 now, in just 9 months of work. So, and that again has to do with, us using the technology here to be able to grow to scale like that. So one, I think it's a leadership question of, looking at your resources. So now I no longer have to ask our core folks, to figure out where new business might fit in their priorities. And yes, it costs, but again, the return on investment on this is huge. There's a lot of funding right now, and I know there might be people that are not from California here, but from the federal level, the president has invested in mental health, and a lot of those dollars are trickling down to the state. So I think really understanding where your state is on there and the opportunities, the grant opportunities there is really important. We certainly have, because of the transformation with CalAIM, we've certainly taken advantage of the different funding sources out there, and I don't think that we would be ready to take advantage of the different sources if we didn't have the vision around how this might roll out and how this might impact our organization. So funding, prioritizing, I mean, like I said, there's in California, there's the cited funding, there's the IPP funding. And so to the extent that you guys can take care, take advantage of those opportunities, that's a way to start this initiative. And I don't, those dollars are not going to be there in a couple of years. So really planning for that, I think, is really important. For us, it basically came down to our mission and vision. Again, we want to be a trusted partner in the state for behavioral health services. And, that's our why. That's our why for why we're doing this, why we're going through this digital transformation. Our strategy tells us how we'll get there. It gives us some direction about how we get there. Ultimately, what we want to impact, though, is what is described here in this circle, in this pie here with the quintuple aim. We're moving towards population health management. We're looking at having equity in behavioral health outcomes with health outcomes. We want to make sure members, clients, customers, patients, whatever you call them, are having have a positive experience with their care from start to end and everything in between. We want to make sure, with the great resignation, that's another challenge that we have, but we want to make sure we take care of our clinicians. And this is a way, this digital transformation is the way to do that. And as you guys can hear here, if you hear how we're just reducing costs, right? I don't have to, if I needed to hire people to manually sort through Excel spreadsheets, I mean, figure out the cost there with the number of staff that you would need to do that. Go multiply that salary and, see if you can use those dollars differently, which is what, we're deciding to do is instead of hire bodies to sort through Excel spreadsheets, and they don't love it. They don't love it. And you hear their pain every time they talk about it, how painful it is. And what's worse is that it's predictable. We know that they're going to experience that pain again next month. So, the cost again of being able to keep your staff, retain them and recruit people because they know they're coming into an environment that's progressive, that's going to really build on their desire to work within our mission, are ways to care for your staff. So I don't think, anything here is at one over the other. I think you can do all 5 of the aims here, and digital transformation is the way to do it. Our implementation strategy, we have 2,000 employees across the state. We have hundreds of programs across the state. And we work in multiple counties. We have multiple payers. So we are not fully through. We don't have Salesforce in all of our departments yet. The goal is to get there. But we started off with the low-hanging fruit. So anything under new business. So today, anything under new business gets developed so that they basically become a turnkey operation, and we can turn it over to, our core team to run the business. That's the goal with new business. So we're not trying to catch up, but we're trying to build our programs so that the consumers that are coming into these new programs has these experience, the staff have the data that they need, the workflow is great and wonderful, it happens all behind them, and they never ever have to struggle with making sure data gets into the right system, whether it's to document the services for an audit, or to get it to billing, or to get it to the outcomes department, for program evaluation. They don't have to worry about all of that the system is taking care, of all of that. So we started with new business, started very slow, very small, although I don't think my team might say it was slow. But, we want to demonstrate the success. And now, I mean, our staff used to be fearful of any kind of digital implementation. We did not enjoy our EHR implementation. And so everyone, anytime they hear anything that has to do with technology, people were always reticent about that experience. And now we cannot roll out Salesforce fast enough in the organization. But it does take, if you want to think about, implementation science, we explored, what tool out there could really solve our pain points. And we spent many years doing that. Once we decided that we were going to, have this structure of new business versus core business, we then needed to do some things, which is the next stage, is program installation, getting ready to develop and design the program, building the infrastructure for the program, but also building the infrastructure for new business. For a long time, it was just me in new business. And so now I think I have a team of 5 people in new business. That program installation stage is key. And so with Erica and her team, going through user stories, them understanding our needs, going through discovery, all of that has to deal with program and implementation and program installation. And I would say that is probably the most important part, because if you design this right, then you have initial implementation where you can test out some of these things and fix things pretty quickly. So fail fast and fix things pretty quickly. That's what new business is all about. Is we take it to initial implementation, we test things out, and then we get to full implementation. So I should be able to turn this over and not worry about the infrastructure of how business is going. And then the programs can innovate and sustain, which are the further phases of implementation science. What you need, though, to do all this, implementation science talks about the drivers, and there are competency drivers, organizational drivers, and leadership drivers. You need to have all 3 drivers working together. So you can't have one and not have the other. It won't work. So the competency driver has to do with, who you're selecting, training, and coaching for these new things. For a while, we were trying to solve our own problems with the same people. And where I would say my colleagues are great, but we think along the same lines. We needed people who thought differently than we do, who could help us solve. And I still don't know all the Salesforce products. That's why I'm never in a call without Erica or Chrissy, because I'll tell them what I need and they'll figure out what license I should get. But that, again, that installation stage, I mean, the selection and the coaching, the people that you want to have in the start are people who are early adopters. They're not afraid to fail fast, learn, and correct, change course quickly. They have the ability to apply information in new settings, and connect the dots in different ways. So again, it's a very different mindset than people who might be really good managers and really good clinicians, but in the context that they know. Organizationally, I report to the chief strategy officer, who reports to the CEO, and but I spend most of my time with the CFO, not only because he controls the money for this, but because he also oversees our IT department. So, that matrix management to really make sure everyone is informed about the process, but having forums for decision making and being able to respond quickly are all part of that organizational structure that you need to support this moving forward. So it's not like something okay, yes, let's do Salesforce and we're going to assign it to staff C. Good luck, let us know how it goes. We meet frequently, to keep this moving. And then, again, just the technical and adaptive leadership skills that we need around these things. And again, there's all of us here, but there's a lot of people behind the scenes that really make this work.
Agreed. I will add one thing, and then Erica, I'll hand it over to you. The other area to look at is when you're looking at budget, is we can also do a process here within Salesforce when you're kind of starting this process journey. We look at technical debt. So if you're using 7 systems to do 7 different things, and each person on your team needs all 7 of those systems, so we're talking 7 different licenses times all the staff that needs that. What we can start doing is saying, okay, well, what these other systems do, can we bring that into Salesforce? Can we consolidate some of this technical debt? And that's another way where we can kind of start doing that initial, what's the return on investment? And then we can start looking at the efficiencies and things that Eleanor was talking about. So there's 2 angles that we can also help you with if that's something that you guys want to do. Erica, do you want to?
Yeah, I was just going to say that, licensing aside too, even if those are non-licensed systems right now, but they're on-prem, there is still a cost to those that's not to be understated, right? So you need to have the server infrastructure, you need to upgrade servers, you need to have the people to manage them, right? Someone doing all of the backups and having all of the air conditioning working, all of those pieces that are part of that cost equation as well. And I'd also say that don't be afraid to come to Salesforce, to Provisio, when you're in that grant phase. Eleanor does it all the time. So to come and say, we're considering this grant, but we want to make sure that in that grant, we're including not just the implementation costs from a people perspective, right? Which is how you're traditionally thinking about it. But what is it going to take from an infrastructure perspective on the technical side? And if the grant response does allow that, we're happy to help you in that effort and help gauge what that might be. It'll be really high level probably, right? Because typically we're kind of in an exploratory phase there, but at least make sure that you're able to, if possible, cover those infrastructure costs.
We have one last slide, which is kind of the same idea, but really focusing the strategy around the quintuple aim. So Eleanor kind of put some examples of moving forward, why you should move forward, and how that actually hits all of these buckets. I don't know if you want to go through a few, but this can help you kind of strategize on, especially if you're looking for health equity.
Well, I think, this slide kind of just tells you the work isn't over. I was actually pretty impressed myself with what we've done in the last year with what Erica just described. But there's more to come. I mean, there's still a whole lot more. Again, if we look at the quintuple aim about, how we're going to impact these different areas, there's a whole lot more to come. I'll start, with, again, just virtual appointments, really getting our portals built out across all of our programs. Chrissy talked about, reduction in technical debt for reducing costs. And again, just think about, not having to hire people to manually enter data. We have people that we've had to hire to enter data in multiple systems because there is just no way to get data automated to flow between a couple of systems. So there are a number of different ways that this reduces costs. A couple of other features that we haven't even mentioned, Einstein next best step is, where it will, I'll stop there. I'll let Chrissy describe Einstein. But, there's other features where it can start to help guide clinicians, if you will, about what to do next. And for us, if we go into value-based care, we need to be able to understand who we're serving and how to best serve them, how to manage that population of people that we will need to manage, because it's not all the same. Looking at utilization, is a very different way of doing business than your fee-for-service financial structure. So, again, things where it helps to improve processes, reduce human error are all, key things that we'll continue to look at. In terms of like advancing health equity, one of the things that CalAIM will do is not require necessarily a diagnosis, which is great because if you have to wait, until you have a diagnosis to receive treatment, then that defeats the whole purpose of prevention. But also, looking at evidence-based practices, one of the criticisms of evidence-based practice is that it's done in such controlled settings and, to populations that are not necessarily similar to those that are done in randomized clinical trials. And we have tons of data. We serve Uplift Family Services, which merged in March to become Pacific Clinics with Pacific Clinics. We've been around for 150 years. We've had an EHR since 2000. So we've got tons of data. We've got tons of data, and we haven't been able to actually look at that data to say who works with what, what works with whom. And so we'd like to get to that point to be able to do that. So, and to build, to build the research based on what makes things evidence-based. And, we have lots of local data that we can look at to contribute to that literature. Another part that I'm interested in personally is, again, who receives treatment and who doesn't receive treatment. There's an assumption with those who receive treatment. One, they might have come to the point where they're going to accept treatment or at least recognize formal mental health services as a form of resource to address problems. There's a whole lot of cultures out there that do not recognize mental health. And so there's a whole lot of people out there that we might not be reaching. And so I'd like to better understand and with some of the features here that Erica described, who's maybe clicking onto our website, but not coming into treatment. Is there a certain profile of people who actually take it to the next step and want treatment versus those that might be toying with the idea or exploring the idea, but not actually, coming into treatment? And so what can we do then to reach out more effectively to those communities? Those are some of the questions that, we want to answer once we get our basic foundation built. Chrissy mentioned, the whole wraparound care for improving.
Hey, Eleanor, can I add something on that treatment versus non-treatment that I'm also hearing is when you have that eligibility. So let's say your grant provides that eligibility and they have 10, I'm just throwing it out, 10 hours of care and they've used one. That service is one that they're not utilizing, like Eleanor said, but also when you think about it from a financial side of things, it's also 9 hours that you could be billing for. So we want to make sure that we're getting them the care and they're utilizing all the services that they need, and that we're eligible to actually bill for those services. So we want to look at the care as well as kind of that low hanging fruit that's sitting there. So who's not using our services in a financial standpoint too? Sorry, Eleanor.
No, thanks for adding that. What you see in improving population health there as an example of, bridging research to clinical practice. There are resources out there. So for example, PracticeWise is a company that looks at all these interventions in the literature, and they rank them according to the different degrees of research support. So, level 1, your most robust, multiple researchers have review it. They have manual treatments, multiple randomized clinical trials, strongest evidence. Level 2, they might not have the manual, but has gone through randomized clinical trials. So they scour the literature out there, and then they put all this information into a database. And we have had that license to be able for our staff to go through and say, I am now seeing client X. This is their demographics, ethnicity, age, and here are the problem areas. Tell me which intervention will be most effective, or where I should start in working with this person. There's that research out there. And right now, though, that's all outside of our workflow. So the question of how can you bring this information, this research, to literally same day impact practice to improve outcomes is, somewhere we also want to take, this work towards. Making sure clinicians have that information real time. I think we always talk about this. Making sure clinicians have their information so that they can do what they need to do to be most effective. Because if they do all that, they're effective in achieving their outcomes, they're documenting their service and not even recognizing they're documenting the service. All this stuff about billing and productivity, that'll follow. So there's a lot of things, we're looking forward to. And, like I mentioned here, just a whole lot of features that I'm sure I don't know of. I'll come up with something where Chrissy and Ben can be challenged in finding that product for us. And then Erica can be challenged in figuring out how to implement it for us.
Who doesn't love a challenge?
It's true.
Erica, any last thoughts before we're gonna probably end early, everyone. So any last thoughts?
Just thank you everyone for spending your time with us today. We had a great group. There were some fantastic questions. Just know that this isn't a journey that you need to take alone. So if you're wondering where to start, how to get started, Provisio is, we'd love to be your partner of choice. There are other partners out there as well. Salesforce solutions engineers and account executives are also ready to help. So just know that you're not alone. We've been through this before, and we'd love to get through this journey with you as well.
And I put up this slide just so if you wanted to jot down email or contact, like Erica said, so if you're not sure who to get a hold of, we will help you. Just contact one of us and we'll get you the right person. If you are already working with your account executive at Salesforce, reach out to them as well. We are all here to help. And then Eleanor, any final thoughts?
No, I would say, you don't have a better team than it's been my pleasure working with the two of you guys. And I know Ben is behind the scene here too. But this is exactly the kind of partnership you want.
Thanks.
Thank you. It's been our honor and privilege as well.
All right. Everyone go grab a cup of coffee, get a snack. We know y'all have meetings, and thanks again. We'll see everyone at Dreamforce. See you at Dreamforce.
Thanks, everyone.
Bye,
All
everyone.
right. Thanks, everybody. Bye-bye.